So recording is now enabled, just so everyone knows. So, okay, so without further ado, let me just introduce Professor Chris Oliver again. Professor Oliver is Emeritus Professor of Neurodevelopmental Disorders at the University of Birmingham. He's also a clinical psychologist and one of the principal investigators on the CHARGE research project. So again, we're delighted to have Chris join us this evening. And I will switch over the video now to Chris to get started. Okay, so you're now spotlighted, Chris. So
okay, thank you very much, Stephen, and good evening, everybody. It's a kind of unexpected pleasure to be with you. I say unexpected because I heard from Caroline yesterday or the day before that she wasn't able to make it this evening. She has given me her slides, and so I will make the presentation on her behalf and take you through the material that she wanted to show. So as it's Caroline's slides and not mine, there might be some pauses and some clunky parts to the presentation, hopefully not quite as bad as Boris Johnson last week with the CBI, but we'll do our best. Just to give you a little bit of context to the presentation, with the CHARGE support group, the program of research has been trying to identify areas of significant concern for families that people with CHARGE might experience, and how to move the research ahead in those areas. And that's been informed by past research that Caroline and others have conducted at the University of Birmingham, in which we've looked across almost 20 genetic syndromes now to identify patterns of cause of these behaviours. And the story is one that we identify some common features that cut across the syndromes, and that allows us, when we become involved with a new syndrome group, that we're hitting the ground running. We've got some ideas on what to do pretty much straight away. And so I'm going to give you a bit of that research story, some of our thinking about that, and then there'll be a presentation by Andrea Thomas, who is doing the work at the University of Birmingham, partway through her PhD and raring to go with the next phases, so that we can see if the things that we have learned for other syndromes would be helpful to people with CHARGE syndrome and their families. So I'm now going to share the screen, which will show Caroline's slides, and hopefully you can see those now. And you'll see the title of the talk around difficult behaviour, pain and sleep. And that's important because those are the three things that Caroline has felt for a while, and the research literature tells us hang together and might help us understand, in particular, the difficult behaviour that people might show. I'm going to use a variety of terms: difficult behaviour, challenging behaviour, a number of others. I've been working in the field about 35 years. The terms change, and I try and keep up, but I don't always succeed on that. There's Caroline, and she works, this is the context, she works alongside three other people, Jane Waite, Hayley Crawford, Joe Moss, at three other universities, and collectively they are the Cerebra Network for Neurodevelopmental Disorders. And different people in that group are focusing on different things: sleep, behaviour, autism, anxiety, and a number of other areas. And together they're leading a program of research over the next 3 years or so. And you can find out more about them there in Facebook, Twitter, and inevitably on the web. So you can look that up and see what they're doing. Twitter group is pretty active, I think, as the Facebook page is, in keeping up to date with what's going on. So that's the context. Some of the information that I'll give you tonight, it's often held, our research papers and Caroline's research papers are held behind publishing paywalls, and we object to that. So we post our research papers on researchgate.net. It's kind of Facebook for nerds like me, where we all post our research information so everybody can see it. We have a website as well, findresources.co.uk, and this covers individual syndromes, but also some of the issues that cut across the syndromes. And also, if you want to follow up on some of the things I mentioned, pain, sleep, for example, you can do so by going to the Cerebral website, .org.uk, and they have parent briefings. These are sort of 7-8 pages of summaries about things like pain, sleep, anxiety, self-injury, sensory sensitivity, those kinds of things. And they're quite useful. They're good, handy resources. So that's where your background information is. So this was Caroline's thinking, really, is that we could cover our current understanding and the limitations of our understanding around difficult behaviour, things like self-injury and aggression. We then want to just say a little bit about the problem of pain, and pain in particular as a neglected cause of some of the behavioural challenges that people show. So things like self-injury, aggression, but also sleep problems. And the idea in the presentation is to show you how those things hang together and to show you how we need to understand those issues much more in charge syndrome in order to have first-line interventions that are available very quickly. So this slide just shows you the prevalence, the percentages of children at ages 3, 5, 7, and 11 who show behaviours that challenge. And what you can immediately see, the red line, children with learning disabilities, about twice as many children with learning disabilities show challenging behaviour as those who do not have learning disabilities. The second thing to notice is how stable those figures are across time. And what that tells us, and follow-up research we've conducted in the past tells us, is that if you show behaviours like self-injury, you've got an 80% chance of showing that behaviour almost 20 years in the future. So these behaviours tend to stay around, and there is a case for early intervention. And the question is, what should we do in that early intervention? So this is some of Andrea Thomas's really exceptional work on taking every research paper she could find published in the world on charge syndrome and working out across all of that research that has been done and peer reviewed and is of reasonable quality. What does it tell us about behaviour and characteristics of charge syndrome? And obviously her focus and Caroline's focus has been on the difficult behaviours, and there you can see them. So aggressive behaviour across all of the studies that have been conducted, about 1 in 2 people with charge syndrome would show aggression to other people. And there, about 4 out of 10 people would show self-injury. Just look to the left there of the self-injury and you'll see sleep difficulties in about 45%. And I'll come back to that. But what this shows us is that these behaviours are common in charge syndrome and they can get in the way of quality of life. We know that across the board, that these have a significant impact on people's capacity to engage in their community, to learn, and general family quality of life. So these challenging behaviours that we see in the previous slide occurring in children, there are particular forms in charge syndrome, and these figures are of course higher than those we saw in the last slide. In other words, charge syndrome appears to have a stronger association with these behaviours than we'd expect by chance. So how do we understand a behaviour like self-injury? Now, this bit of Caroline's slides reminded me of where I started 35 years ago when I was studying self-injury. And what we thought, the main thinking at the time was this was a learned behavior, what we call an operant behavior, and it's sensitive to environmental reinforcement or to reward, particularly from other people. So the model was the ABC. I'm sure you're familiar with this, but there is an antecedent or a trigger preceding the behavior itself occurs, and then there's a consequence, and that's usually a response by other people that might be rewarding, and that leads to the behavior occurring again under the same circumstances. So this was a very simple model, but it's incredibly powerful. There's a lot of evidence to support this coming from studies of cause, but also studies of intervention that tell us that this is a very common cause of difficult behavior. Let's just look at it in a little bit more detail, because when we do that, it does help us understand why this happens. So imagine seeing a child or anybody showing self-injury, for example, banging their head. When we see that, we find it aversive, of course we do, and we are concerned, frustrated, anxious, confused, distressed. Of course we are when we see that kind of behavior. That leads us to act. It's in our job description. And when we do, we engage with the person, and we would comfort, we would reprimand perhaps, offer something, restrain, try to protect someone. We would occupy people, distract. We will try a number of different things in order to get that behavior to stop. We know those things can be a reward. They're inadvertent. We don't mean to reward the behavior, but those things are rewarding. Rewarding behavior makes it stronger, makes it more likely to occur in the future. And the next time the person has a need for others to do or give something, they show self-injury, we find it aversive, we act, we engage, and we go around again. And it's a very, very powerful behavior, something like self-injury. People cannot ignore it, and that's partly well, that's a significant component of the problem. But this was how classically we understood self-injury. We felt like we didn't need to know anything more. We just needed to know this as a learned behavior. And the kind of circuit you're seeing there is about positive reinforcement or reward. There's also negative reinforcement. So for example, if someone's being asked to do something they don't want to do, they show self-injury, they get the same trap running, but we disengage, we stop asking them to do something, and that makes the behavior stronger in the future. And when you think about it, that behavior then is a lot like communication. And the evidence for this, as I mentioned, is strong, overwhelming. And I guess for many years, we thought, well, that's the whole story. We've just got to get it right. And that led us down the road of thinking, okay, we've got something before the behavior that triggers the behavior and then a consequence. So what we could do is we can change the antecedent, change the A, make those things that the person finds aversive or unpleasant, make them more pleasant. We can increase the availability of attention, for example, so people don't feel the need to show self-injury to gain attention. We could also change the B, the behavior, and we could teach people a different way of saying, I don't want to do something, or I need some help, or I want someone to come over. Or we can reduce or remove the reinforcement, a lot more difficult than we ever thought it would be. So there were these, if you like, this was an applied behavior analytic approach, and it gave us a way of responding to these behaviors when they were learned. So that was the position we got. And then, of course, we started to realize, forgive this very busy slide, but we started to realize, and this was a paper between myself and Caroline in 2015, and what we said is, well, if that learning argument is the whole story, then the people showing the behaviors, it should be random. It should not be associated with any particular child characteristic or any other behavior, because it's learned, it's all to do with the environment. It should be randomly distributed amongst all people. Caroline went to the literature, and this is what she showed us. She reviewed all of the papers she could find, and in that she found, well, actually, people with autism are more likely to show self-injury. Those with some genetic syndromes are more likely. Those showing repetitive behaviour are more likely. And then she sounds something very nice, that health problems seem to be associated with a greater chance of self-injury. Now, if we said that behaviour is learned and a bit like communication, why should health problems have anything to do with this? So this told us that there was more to the story than we first thought. So the problem of pain, I think, as I moved through my line of research and Caroline moved through hers, I think we both realised this is significant. If we can crack this problem, if pain is associated with behaviour and we can crack the problem, then it's a very immediate intervention in order to reduce behaviour. Not just that, but it's also a quality of life issue and an equal access to healthcare issue. But what we knew was the problem was that if you are supporting a child or an adult who is non-verbal, has a severe degree of intellectual disability, there's a very significant problem. Because being able to tell someone about pain, you first of all have to identify the sensation of pain in yourself. You then have to label it in a way, and then you have to communicate that to other people, and also believe that communicating that to someone else is a worthwhile thing to do. So there are a number of barriers in terms of trying to know if someone is in pain. And I'm sure we've all been there in either our family settings or our careers, in feeling that someone might be in pain, but knowing that they're not able to tell us what's wrong. And that was a significant problem. So the other question that was posed was, is that pain associated with things like self-injury? And we did this study in another genetic disorder called tuberous sclerosis complex. And here we showed that if you were showing self-injury, then you had a much higher score on a measure of pain, something called the non-communicating child pain checklist, than if you were not showing self-injury. So you were showing more pain behaviours if you were showing self-injury than if you were. And I know what you're thinking, that's hardly surprising, because if you injure yourself, then you're likely to show pain behaviours. But that didn't seem to be the case. I'll come back to that in a second. Here's another example where in Cornelia-de-Lange syndrome, we had studied self-injury. This is where I started in my PhD. Studied self-injury for many, many years. And I was an absolute fervent believer that the behaviour was learned. And in Cornelia-de-Lange, I was absolutely wrong. So in Cornelia-de-Lange, you see a lot of GI disorders, gastrointestinal disorders, and in particular reflux. And so we see a number of behaviours there on the right hand of the screen there, where people who are experiencing reflux would drink excessively, cough, sleep sitting propped up, sleep sitting or propped up, put their fingers in their mouth a lot, salivate excessively, teeth grinding, very interestingly. And these were signs of, we thought, were signs of reflux. And reflux was very common. About 80–90% of people had this. And what we showed is that those signs on the right were more common in people showing self-injury than those not showing self-injury. And there was loads of anecdotal evidence that if people were treated with a fundoplication for the, this is tightening the muscle in the top of the stomach, or they were treated with proton pump inhibitors, then the self-injury tended to dissipate. And that was my experience of that clinically. So we had quite a bit of evidence then that pain was related to self-injury. And Caroline took that general rule, that general law from individual syndromes, tuberous sclerosis, Cornelia-de-Lange, and went to a large group, autism. And this figure shows you the percentage of children and adults with autism who had experienced a health problem in the previous month. It shocked me. 60% had a health problem in the previous month of adults, 40% of children. She then asked the question, well, if you've had a health problem, are you more likely to show self-injury? And the answer was yes. So those showing self-injury, the children, 50% of those showing self-injury had a health problem in the last month, and it was only about 25% of those with no health problem. Now, what was really interesting, going back to which causes which, self-injury, pain, self-injury, well, people here had middle ear infections, reflux, and skin disorders. Now, interestingly, reflux and middle ear infections are related. Even in typically developing children, children get middle ear infections from reflux. So there was a good sense here that in autism, we were also seeing this relationship. Then she showed, really importantly, just on the right there, that actually health problems were highly predictive, not just of self-injury on the left, but severe self-injury on the right. So if you had a health problem, you are 3.5 times more likely, roughly, to show very severe self-injury. So this was really important because we know what to do about reflux, skin conditions, and middle ear infections. We know what to do. And also, just to go back to that learning theory point, if the behaviour was learned, we shouldn't see these associations. They shouldn't be relevant, but clearly they are. So, where have we got to? So we've got, on the one hand, we've got this learned behaviour going on, and I don't think we should ever rule that out. Should never rule that out. It is important. But we've also got pain hanging around and somehow involved. And there are 2 ways that that might be influential. So here we've got our learning cycle. This is the negative reinforcement or escape one. And one idea is, the question here was, look, where does the first act of self-injury come from for it to be rewarded? When did the first one has to happen for another reason? Can't have been rewarded in the past because it hasn't happened yet. And it may be pain causes the initial act of self-injury, and then it is influenced by the environment. Think back to the early intervention. If only we get rid of the pain causing the self-injury, then we don't get into the learning cycle, then it doesn't persist over time. But there's another really interesting link, and it's this, that actually in this negative reinforcement or escape, there's quite a bit of evidence that actually if you are asked to do a task and you have learned to self-injure to escape from that task, tasks, for example, are made much worse. It's more aversive if you're in pain at the same time. And you know this yourself. If you're asked to do something when you're tired, when you're hungry, when you're in pain, it's much more aversive. You are more motivated to show an escape behaviour. So here we could influence the motivation even when the behaviour is learned and up and running, if we can decrease the pain. One other thought is this. This is called pain gating. So if you have a physical disorder, for example, reflux, and you pull your hair, we think it gates the other type of pain. You can only feel one type of pain at a time. And so if you have pain from the reflux, that's the chronic pain. If you pull your hair, it temporarily gates the more severe pain. And so you might pull your hair more. Of course, if you keep pulling it, you might have another injury that gives a physical disorder. And so you go around again. So that's why it's quite important. So we can assess pain. I've been working on this for a while. This is called the FLAC, face, legs, activity, crying, consolability. 5 signs that we look for. Remember that one, legs, because I'll come back to it. Legs kicking is often a sign of pain. So we now know that challenging behaviours are related to the environment, shown that in lots of studies. We understand that learning component, but there is a risk that is associated with some person characteristics, for example, health, presence of autism, more severe degree of intellectual disability, repetitive behaviour, and so on. There are other risk markers, so we've got to build those in, otherwise we haven't got a complete model. Pain may drive risk, and I think it's probably one of the major drivers that we would get the most out of in terms of intervention, if we could understand that and decrease it. But in charge syndrome, and this come up in Andrea's meta-analysis and her review of the literature, we don't know how those factors work in charge syndrome, and we need to know more about that. Hang on to that for a second, because there's another line that we can bring into the research that will help us a bit further, and that's sleep. So in typically developing children, painful health conditions are associated with poor sleep. That's not surprising, of course, but it's bidirectional. If you have poor sleep one night, you have higher pain scores the following day. So it appears that fatigue makes you experience pain more. So that's kind of interesting. In children with intellectual disability, untreated pain is associated with sleep problems, less sleep duration, parasomnias, for example, and sleep disordered breathing. And daytime behaviour problems are correlated with night waking and poor sleep quality. You can see us hanging together now. And if you intervene for sleep problems in children with intellectual disability, daytime challenging behaviour goes down. So this is kind of interesting now, because now we've got pain and sleep as two targets. They are closely linked with each other, but also probably with the behavioural outcome. So we may think of pain just causing challenging behaviour, or pain causing sleep problems and then causing challenging behaviour. Whatever the route is, clearly we've got two targets on the left there that we can go after if we understand how they work in charge syndrome. So how do we assess sleep? Well, this is where Caroline's expertise comes in. She led a program of sleep research, as well as has led a program of self-injury research. And she worked out a way of, for really quite disabled children, being able to characterize their sleep using something called an auti watch. That's that little watch thing in the bottom left-hand corner. It's a bit like a Fitbit, and it records any movement. Worked out a way of daytime behaviour. She also looked at impact on parental well-being, and did so-called video somnography. In other words, videoing the children at night and then recording their behaviour. She did this again in very high-risk syndromes. In Smith-Magenis, self-injury in about 98%, aggression about 80%, quite difficult behaviours, very difficult sleep pattern, children with autism and children with Angelman syndrome. So these are challenging groups to collect good sleep data on, and also collected some other data there on typically developing children and on the parents as well, to see how their sleep was doing. This is the sort of data she was able to get, and this was so helpful to the parents in being able to show other people, look, it's not just me saying his sleep is poor, look at the record. And this is actigraphy data. So when you see those little black marks, it means the child has moved. And this is 7 consecutive days, and we're running from midday to midday across each day. And we can see when the child goes to bed, when they get up, just by, you just make a little record on the actigraph, on the Fitbit, and that's the amount of time in bed. You can then work out the total sleep time, which is the total amount of time that the child is still. We're not seeing the black marks, so they're not moving. And then we can work out sleep efficiency. So that's a percentage of time in bed that the child's actually asleep. So the children might go to bed at 8 o'clock and get up at 7. It didn't mean they slept for that time, you know that. And this gives us a good variable called wake after sleep onset, or WASO. So it allows us to know that after the children went to sleep, they then woke up. And that's important to know that they are waking, but also, why are they waking? Because once they're awake, then all sorts of other things follow on. And then you've got sleep onset latency. How long after being put to bed is it before you go to sleep? So this all comes from that little Fitbit and gives you a pretty thorough report, and also, pretty incontrovertible evidence about poor sleep. It's important in that way. So let's just have a look at this. What you can then think about in these two syndromes that Caroline looked at with others, Smith-Magenis and Angelman, you can look at settle in, when you go to sleep, and wake in. And Georgie Agar was an outstanding PhD student who worked on this. And what she did is code all the night vision video. She watched children sleep for 5,130 minutes, and she coded every bit of it. And it allowed her to look at child behavior, whether they settled, whether they signaled. Signaled means calling out for mum, or shouting, or making some kind of noise to let someone know that you're awake. But she also worked out a way of coding some pain behaviours, in particular leg movements. You remember I mentioned those with the flak. And then she recorded parent behaviour and whether the parent was with or near the child, so we could work out what's going on. So this is an example. This is a child waking. You can see they wake right in the middle of that, and that's the probability of leg movements. And you can see it's pretty low on the left there, the open squares. And then the second they are waking, there's loads and loads of leg movements, and then they calm down. And this is negative vocalizations. It's what we call negative vocalizations, crying. And these are almost exactly the same as the leg movements. This is a child with Angelman syndrome. Again, you can see the leg movements absolutely rocket at the time that they wake. And then interestingly, there's a bit of a delay, about 5 minutes after waking. Then you see the signaling. So this is then calling out. And a point here is that if those leg movements, if the calling out is caused by waking up, and the waking up is caused by pain, as indicated by the leg movements, if we deal with the pain, we don't get the leg movements, we don't get the waking, we don't get the calling out. So you've got right back to the root cause of waking at the outset. The last thing Georgie Agar did with Caroline was to say, well, does this affect behaviour next day? The answer is yes. So in the autism group, it was both wake after sleep onset. The more you woke after you went to sleep, and your irritability predicted challenging behaviour the next day. And in the Smith-Magenis group, if you woke at night, then you showed more challenging behaviour the next day. So I think you can see from that we've got kind of quite an interesting relationship here and a way of moving ahead. Pain and sleep are worth studying in their own right because they are quality of life issues for everybody. But if pain is a common cause of self-injury and sleep problem, then we've really got to root in to improving quality of life and behaviour and the sleep. We know that painful health conditions are very common in charge syndrome. So when we were studying the different syndromes, we went, for example, from Cornelia de Lange to tuberous sclerosis because we knew there were health problems in tuberous sclerosis, and we were able then to find the link with self-injury in that group. These painful health conditions increase the risk of difficult behaviour. It increases nighttime waking and settling time, the time taken to settle children at night, which can in turn increase difficult behaviour. So we've got that link. And this would give us a first line intervention. 35 years ago, I would say you have to assess how the behaviour is learned, and then we'll unravel it. Now, if ever I see someone, I say, we have to rule out pain first. That's the first thing we do. This is Caroline's message. We need to understand all of this better in charge. And I think she's absolutely right. I think there is a real gain to be made here in understanding each of those behaviours in its own right, but also the link between them. And that's the project that we want to undertake now. And yeah, I'll stop there because I'm a little bit over time. I'll just acknowledge all of the, I'm sure Caroline would want to acknowledge the funders, and on the right, collaborators. Can see a good list of people there, and especially, as ever, the children and families who took part in all those research projects to bring us to this point where we can take the lessons learned from other syndromes and bring them to charge syndrome to see if we're then able to see that the rules move across and that constantly the lessons and the intervention also learn across. So I'll stop there. Thank you very much.
Thank you very much, Chris. That was really informative. I'm conscious of time also, so I'm going to move quickly on to moving the spotlight to Andrea. There we go. Yeah, you should be spotlighted now, Andrea.
That's wonderful, thank you. Hi everybody. I just want to say thank you so much to Chris for a wonderful presentation, and for stepping in at the last minute. It's very difficult to speak to somebody else's slides, and it was as always very good. So I'm going to start off. I'm just going to share my screen. Just bear with me. Okay, I think I'm there. There we go. So, hello to everybody. So my name's Andrea Thomas. As we said, I'm a PhD student at the University of Birmingham. And my PhD is all about charge syndrome. And I'm working to understand some of the behaviours that Chris has talked about that are sometimes reported in charge syndrome. So I'm going to share with you some of the work that I've been doing this evening. So before I start, it's important to say that my work is supervised and draws on the expertise of some quite incredible clinical and research professionals across a network of institutions, all of whom are committed to improving the lives of people with complex needs and their families. So in my presentation, I'd like to share with you a bit about the research that I've done so far, and also the research that I'm working on at the moment, and some potential opportunities for you to help me with that. Okay. So when I started my PhD, Chris, myself, Caroline, and our group, we had a lot of discussions about how we might understand behaviour in charge syndrome. You see, charge really is quite an unusual syndrome in that every person that I've met with charge syndrome is so wonderfully, uniquely different. But of course, there's also similarities, and there's shared experiences, challenges and achievements. And as Chris was saying earlier, behaviours are shaped by thoughts and feelings inside the body, but also experiences in the moment, and also really over a lifetime. So we decided the best place to start was to conduct a systematic review. And a systematic review, is a way of collecting and reviewing the best available information about a particular topic using a set of standardised guidelines. We used a systematic review approach to find out all the research papers that had been written and included information about behaviour, sleep and developmental learning delay in at least 5 people who were reported to have charge syndrome. We found 914 papers that had been written about charge syndrome over the years. We read each one and sorted through them carefully. And by the end, we had 47 research papers that reported in total on 1,583 children and adults with charge syndrome. So we made a note of every behaviour, sleep difficulty or developmental learning delay that was reported and how many people were affected. Then we looked at what physical characteristics and diagnostic signs each of these people experienced. And this allowed us to explore whether people with certain physical conditions, for example, might be more likely to show certain behaviours or a different sleep pattern. We then looked at what physical characteristics and conditions, physical characteristics and diagnostic signs each of these people experienced. Yeah, sorry. Repeating myself. So we used a statistical approach, which is called quality weighted meta-analysis, that works out the percentage and also the associations between different characteristics. And whoops, here we are. This figure is taken from the meta-analysis that I did. So there's a lot of information there, so just bear with me and I'll talk you through it. Okay, so this green section is made up of the behavioural, cognitive, which is like the learning, and the sleep characteristics that we found. And the size of each segment represents the percentage of people with Charge syndrome reported to show that characteristic. What was particularly striking was the 48% occurrence of the prevalence of behaviours that are described as aggressive, the 42% prevalence of self-injurious behaviour, and the 45% prevalence of sleep difficulties. And it's these findings that have given me the direction for the research that I'm doing now. So moving around the circle, the orange section here outlines the percentages of the individuals' different signs of Charge syndrome diagnosis. The blue section shows percentages with diagnostic signs that are often seen in Charge syndrome, but are also seen in other diagnoses. And the yellow section shows the percentage with different physical characteristics and conditions. Oops. And putting this together meant that we could see where the associations were between the characteristics. And so these associations are shown with the black lines. So just moving back to the main figure, the one thing that we found that was quite interesting with these associations was that sleep and growth were associated, which is quite interesting because disrupted sleep does often lead to disrupted growth hormone. Okay, so drawing on the findings, I'm going to talk about the research that I'm doing now. So we have 3 studies that we're running. Now, I'll say from the off that at this time, we're only recruiting families with a child with Charge syndrome aged between 4 and 15 years. We certainly have a lot more to learn about development over the lifetime, but for now, we think it's important to focus on one age group at a time. We've heard from a few adults and carers of adults with Charge syndrome who'd like to get involved with our research, and that'd be brilliant. And I'll share a link at the end to a website that's got a database, and you can sign up to that database to be contacted about future research opportunities. So, whoops. We're currently running we're currently running an online survey, an interview study, and at the start of next year, we're opening up a sleep study. So I'll just talk you through these. So the first of our studies is an online survey. And the aim of this study is to understand more about a range of behaviours and abilities children with Charge syndrome show. And these include repetitive behaviours, hyperactivity, mood, behaviours that challenge, social functioning, sleep and health. We also want to understand more about your family's well-being and also the impacts of COVID-19. The more participants, the more parents that kindly volunteer their time to take part in the survey, the more meaningful these results are going to be. So far, we've had 25 parents that have kindly completed the survey. Our target is 70. A good response will provide new and valuable information about child syndrome in the future, and we hope to follow up on the development of the children and families that take part in this research. The second study that we're running right now is an interview study. The aim of the study is to understand more about potential functions of behaviours, something that Chris was mentioning earlier, and how communication, daily living skills, social and motor skills directly or indirectly affects behaviour. So the interview includes what we call a functional analysis, and the questions we ask investigate the potential triggers or functions of behaviours. And the functions we look at are things like physical discomfort, escape from social attention, reinstatement of routine or repetitive behaviour. And after the study, I'll write you an individualised feedback report that from what we found in the study, usually within 2 to 3 weeks. Okay, so this is a very brief example of the report that you'd receive. The actual report is about 7 pages. As you can see, it includes a short summary of information about the presence and severity of your child's behaviours and potential functions of these behaviours. It also provides details about your child's current strengths in communication, daily living skills and socialisation. And you're very welcome to share this report with professionals involved in your child's care. The interview is completed over the phone or over Zoom, if that's easier. I'm a carer myself with 3 children and I work very flexibly. So I'm more than happy to complete interviews in an evening or over the weekend if that's easier. So we know from our earlier work and from talking to parents that for some people, for some families, sleep can be a real challenge. Now, over the last few years, we've been looking at a different way of objectively measuring sleep. And as Chris mentioned, this is called actigraphy. And we found actigraphy to be really successful in measuring sleep in children with tuberous sclerosis complex, with Angelman syndrome and with Smith-Magenis syndrome. And there hasn't been any research so far that's measured sleep in child syndrome in this way. And we feel that it's really important to get this research done. It'd be wonderful if you think that you could help us with this. The ActiWatch we use, which is pictured here, looks a bit like a Fitbit. So your child can wear it either on their wrist or on their ankle, and they can wear it either on top of or underneath clothes. If you think that you would like to take part in the study, but you're not sure if your child would tolerate wearing the watch, we can send you out a dummy watch and then you can try that beforehand to see. For parents, we provide you with a research diary, and there's a very brief section that you fill in each morning and evening. The key sections of the diary ask you to rate your child's behaviour during the day and ask you to observe your child for what we call behavioural observations of pain. And again, we'd walk you through this observation and make sure that you were fully happy with how to do that. Again, of course, a good response would provide new and valuable information for us. So you can access information or you can register to take part in any of our studies or express an interest in taking part in the sleep study, which they will start early next year at our website, which is chargeproject.org.uk. I'll also say that you can take part in any of the studies individually or in any order. If you take part in one study, it does not mean that you're under any obligation to take part in any of the other studies. We sincerely appreciate you volunteering your time for this research, because without families like yours, this research just wouldn't be possible. Our website is also where you'll find the link that I spoke about to sign up to our regular participant database. And the database includes the names and contact details of individuals and families who would like to be contacted about future research opportunities as they come up. So thank you for listening. We've run over slightly, but I'm very happy to answer any questions that anybody might have. So thank you. Whoops. I'll just stop my screen share. There we go. Thank you.
That's brilliant. Thank you, and Andrea, really interesting. So moving on to the next portion of this evening is sort of the Q&A section. That's been kindly chaired by Gail Juice, who's an expert in charge herself. Gail, are you happy to sort of take it from here?
Yeah.
Okay.
Is that okay? So a few people.
I will just I'm just going to stop the recording at this stage.
Okay, yeah, do that first.